Hi there, it's Kathy Cates and Melissa Hines from the Institute for Pelvic Health.
And you're watching Demystifying the Pelvic Floor, weekly videos providing real and simplified pelvic floor education for your real clinical situations. We've got you covered. Module 6, case study number 1.
So, subjective is a 48-year-old female who presents with 8 months of painful sex. Pain occurs with initial penetration, and there's no pain previously and no trauma history. So, here we're starting to think pain with initial penetration could be some vaginal atrophy or some potential dryness. Her cycle is irregular for the last year. Cycles range between 22 to 38 days. They're not heavy, but can be painful. Urinary, no dysuria, urgency, some frequency. Bowel pattern is once a day, no straining. Bristol stool is 4, so soft and formed, which is good. G2, P2, and SVD, each with grade 1 tearing. And long-standing neck pain. She's seeing a PT for this. No medications. She's a mom of 2, happily married to same opposite sex partner of 20 years and a homemaker. She plays on a women's hockey team during the winter months, tennis in the warmer months, yoga 1 to 2 times per week, and long dog walks most days. So very active, eats very healthy, lots of fruits and veggies, organic meats, adequate water intake, and about 1 glass of wine per week.
So upon examination, we see she's alert and oriented times 3. And we're really going to hone in on the musculoskeletal objective findings as well as the GU objective findings. So when we look at her standing, we see significant pronation bilaterally. We see that the cervical spine is in excessive flexion, or the chin is very much pulled down towards the chest. When we look at the shoulders, we see her left shoulder is elevated and that left scapula is protracted or pulled forward. Her thoracic curve is mildly kyphotic. Her lumbar curve, there's mild lordosis. Upon palpation of her abdomen, we find tenderness to palpation suprapubically with dense trigger points throughout the entire bilateral lower quadrant. The distance between the bottom of the lateral rib cage and top of the iliac crest, we note, is shortened on the left. So that tells us she has a left upslip. And we also notice that she has a right ASIS with anterior rotation. So go ahead, Melissa.
So why is this all important? So with the thoracic kyphosis, because of that protraction of the shoulders and that rounded of the upper back, that creates a shortening of the abdominal area, which will then create trigger points throughout. So that's important to note, especially with someone with some sort of pelvic pain. And then again, when we talk about this iliac crest being compressed on the left side, that QL being tight is very significant for people with any dyspareunia because it will throw off the entire internal pelvic floor muscles. If the left QL is short and tight, then generally the right pelvic floor gets tight as well as the entire pelvic floor, but generally the pelvic floor will compensate for any external tightness. So that's why with any pelvic floor issue, it's so important to really take note of standing postural assessment because it will tell you a lot of things.
And Melissa, could you help us understand why, looking at where she's carrying the weight on her feet, for example, that significant pronation, how that can help us as well?
Yeah, so with pronation, if the feet are flat, generally it creates tightness throughout that whole medial line of the leg. So through the adductors. It often can create a narrow base of support, and that will create hypertonicity in the adductors. Those attach on to the bulbospongiosis, STP, and that whole kind of pelvic floor area at the pubic bone. So when those are tight, that will create anterior rotation of the pelvis or just tightness throughout the pelvic floor, especially superficially in that bulbospongiosis, which this woman has initial penetration pain. So you are thinking it could be bulbospongiosis, hypertonicity, as well as some other pelvic floor muscles.
And as far as the standing and the cervical spine and her shoulders and even the thoracic evaluation, these are all things that we can start to look at while we're chatting with our patient, while they're sitting down. And then you can just quickly have them stand up to check out their lumbar curve and to look at how they're distributing the weight across their feet. And then hopping up onto that exam table, you can quickly do that abdominal assessment. And then you can quickly do the assessment to see if there's any type of upslip and any kind of anterior rotation. So this can all be done in a short amount of time, especially once you get more comfortable looking at people this way and just going right in to assess these things. So then moving on to the GU, objective findings. When we look at the labia minora, we see some dryness and mild erythema. And we also see some changes in architecture of the right inferior lip or resorption. So what does that mean? Like, so we're like, there's dryness, a little bit of redness. You know, she's got those irregular cycles. She's probably perimenopausal. So we're really thinking about some type of like vulvovaginal atrophic component, right? And when that tissue doesn't have the estrogen, the testosterone, and the hormones that it needs, then you're going to start to see some actual changes in the architecture. So you may see some resorption of the actual labia. And then when we spread the labia minora apart and look at that vestibule, we see she doesn't have erythema. When we do the Q-tip test, we do, and we've done it 2 to 3 times, right? Because it's always a good idea to do it 2 to 3 times to really get an accurate sense of where, if and where there are those tender to palpation areas. And we note she has tenderness to palpation between 5 and 7 o'clock. So we're already now thinking, between 5 and 7 o'clock, we're starting to think about pelvic floor muscle hypertonicity. Then we're going to jump over the vaginal vault for just a second because these are bimanual findings, right? So when we palpate her bulbospongiosis, we find tenderness to palpation on both sides, as well as the obturator internus and on the right pubococcygeus. So her pelvic floor motor control is poor, but symmetrical. Pelvic floor drop is poor, and her contraction or her ability to do that Kegel is 3 out of 5 with a poor lift. So that would all be, oh, sorry, Melissa, go ahead.
So with a contraction or a Kegel, if you can remember, it's not only about the squeeze that you're checking. You want to make sure that they're actually getting a lift too. So like they're trying to pull your finger up and in towards their belly button. So with this, 3 out of 5 is, decent, but she doesn't have any lift of any kind, which is significant with any hypertonicity of the muscles because they just can't do their job.
Totally. And then with the speculum exam, she doesn't have any pain with insertion of the speculum. But we do note that throughout the entire vaginal vault, we see mild atrophy. So sort of more on the pale pink side instead of that like more healthy glistening, with like lots of rugae and stuff like that.
And that's a wrap. Did you like this video? If so, hit like and subscribe. Please share with your colleagues and comment and let us know your biggest challenges in taking care of patients with pelvic floor dysfunction.
And subscribe to our email list at instituteforpelvichealth.com to get your free guide, 4 tips for managing your challenging pelvic exam. You'll get access to our weekly pelvic health content.
And be sure to find us on Instagram, Facebook, and LinkedIn, where we'll post more pelvic health tips. And we're thrilled to announce that we launched Beyond the Kegel, the only interdisciplinary AANP accredited online course for NPs and CNMs.
Beyond the Kegel is 6 modules packed with practical information that you most likely didn't get in your training. Plus, you'll get our digital clinician resource finder that includes templates, patient education handouts in English and Spanish, hands-on demos, everything you need to confidently help your patients with pelvic floor dysfunction. By simplifying the pelvic floor, we'll improve patient outcomes and your provider experience. Thanks for watching and spreading the word. Now let's revolutionize pelvic health. We'll see you soon.